We are very proud to have with us esteemed guests today. And today is a very special occasion for us because it's something that we are talking about World Diabetes Day, something which is very important to the community at large who is treating diabetes. 2020 has been declared the year of the nurse. And rightly so, the theme of this year's World Diabetes Day is Nurses Make the Difference. RSSDI feels proud to dedicate this program of Diabetes Bytes to the entire nursing profession on World Diabetes Day. Walk down the corridors of any hospital. For a patient, the presence of the familiar face of their nurse, who brims with kindness, someone who holds their hand in distress and gives them strength and hope of recovery, makes all the difference between life and death. They make the real difference in people's lives, sometimes at the beginning and sometimes at the end. We are privileged and honored today to have with us four esteemed guests with whom we are going to spend next 1 hour discussing the role of nurses in managing patients with diabetes. I welcome Dr. Andrew Bolton. Dr. Andrew Bolton is the president of International Diabetes Federation. He is a graduate of Newcastle and subsequently trained in Sheffield and Miami prior to accepting an appointment at Manchester University. He has authored more than 550 peer-reviewed manuscripts and book chapters, mainly on diabetes lower limb and renal complications. He's received numerous awards. Prominent among this is the ADA's Roger Picario Lectureship, the ESD Camillo Golgi Prize, and was the first recipient of the International Award on Diabetic Foot Research. He was the 2008 winner of the ADA's Harold Rifkin Award for Distinguished International Service in Diabetes. I think the list goes on, and I think I can just continue giving all his accomplishments. But one another thing that I would really like to talk is he's the previous editor of Diabetes Medicine, and he's currently the senior associate editor of Diabetes Care. And in 2019, he was ranked the #1 UK diabetes researcher in the field of complications. So we welcome Dr. Andrew Bolton to this meeting today. Uh, I would also like to introduce, in the same breath, Dr. Akhtar Hussain. He's the president-elect of the International Diabetes Federation. He's from Bodø, Norway, and is currently the professor at the Nord University and a guest professor of medicine at the Federal University of Ceará, Brazil, and also co-chair and professor at the Center of Global Health, Bangladesh Diabetes Association, Bangladesh University of Health Sciences. He's currently going to serve as the president-elect since 2019 and also the current president of the Diabetes Asian Study Group and a mastermind behind many important projects on public health importance. Our next important guest today is, of course, somebody whom we are all familiar with, Dr. Shashank Joshi. He's the chair of the International Diabetes Federation of Southeast Asia and the past president of the RSSDI. He's got numerous publications, book chapters, awards to his credit. And I think the list is so huge that I think the entire hour I can fill in talking about his accomplishments. But we are really honored to have Dr. Shashank Joshi with us in this program. And not the least, but our current sitting president of the RSSDI, Dr. Bansi Sabu, a friend to all and somebody who's so dynamic and full of energy. I think he's brought so many changes in the country. He's got numerous publications, research papers, and chapters, and probably he's a driving force for so many changes in diabetes, initiatives across the country. I welcome all four of our esteemed guests to this program. Let me begin by asking Dr. Bolton that as an IDF president, you have seen the healthcare systems in various regions of the world. I'm sure in your travels, you have noticed a wide disparity in healthcare in different regions of very best to the most poor care systems. How can the world community bridge this gap and bring some uniformity of care?
Well, thank you very much, and it's a pleasure to be with you. First of all, let me say that, of course, this week is World Diabetes Day in 2 days' time, which is, of course, the birth date of Banting, one of the discoverers of insulin. And we established this at the IDF some 30 years ago, and this is the 30th World Diabetes Day. And this was adopted and brought into United Nations by a really important document in 2007. So this has been adopted. the nurse, in our view, is key to diabetes care. You mentioned you see nurses walking down the hospital corridor. This is true. But what we really want to see is nurses in the community, in the clinics, not necessarily on the hospital wards, but outside, helping people with diabetes. They are the key link between the person with diabetes and many other healthcare professionals. It's 200 years since the birth of Florence Nightingale, who was, of course, the champion and the modern developer of nursing as a profession, and it's 200 years ago. Hence, we're joining the WHO in recognizing the importance of the nurse. And if you look globally in healthcare professionals, the nurses account for more than 50%. So these are critical. And I think in developing countries, what we need to see is the nurse playing a role outside of the hospital as the link, perhaps visiting patients and people with diabetes at their homes, and being the link between the other healthcare professional and the actual patient. And I think what we're seeing in many Western countries, including USA and UK, is the nurse as the nurse educator, the nurse able to prescribe insulin, prescribe oral hypoglycemics. And they are having an absolutely pivotal role in education. Not only that, in screening. And we've shown that nurses are just as good, for example, in doing a simple foot check as a physician or a podiatrist, if trained. So what we're calling for this year is the expansion of nurses in diabetes. Let me tell you a story. One of my first jobs in the EASD, so more than 25 years ago, was to be in charge of European postgraduate education. And the nurse was just emerging as a key member of the team. And I would go to former Eastern Bloc countries and Soviet countries and Warsaw Pact countries. And we would arrive as a team, and I'd always have a diabetes nurse with me. And I remember one occasion going to one of those countries, and we arrived as a group. We sat down with the consultants, and one of them clapped his hands and ran away. And the nurse came running in with a tea of tray and vodka. Now, to which my nurse, who I'd taken with me from another European country, grabbed hold of the professor, tugged him away, said, "No, the nurses look after the patient. You can get the tea and the vodka." And that was the start. So we've had an impact in Eastern Europe, the nurses having an increasing role, and we'd love to see that across the world. This is going to help in the care of people with diabetes.
So expanding on what you just said, the key factor is, of course, how well trained they are. And that's a very important aspect that we do find lacking in some parts of the world. So education and training remains the key, and we have very few specialized centers to give high quality training to our paramedical healthcare staff. So from the developed world, how do you perceive this? And I'm going to ask Bansi and Shashank to talk about it from the reference of the developing world.
Can I just say one thing first?
Yeah.
As part of this year of the diabetes nurse, of course, culminating this Saturday, which is the actual day, but we'd like to across the year. IDF now, as you know, has a school of diabetes, and we have training for nurses and educators. And we're offering this. This is certified courses that you get CME credits for, free of charge to all nurses and educators in diabetes for the next few months. So this is available. This is a start. But what we need to do is have the doctors, and I travel all over the world, not this year, sadly, but none of us is. But I travel and I see the nurse has a secondary role in many countries. But they should be equal around the table. And a team is not like communism where some people are more equal than others. It should be true. We're all part of this team, and each of us has a role. The nurse in screening, treatment, education.
So I would ask Dr. Shashank and Dr. Bansi to talk about how this is relevant in our population, in the Southeast Asia and some of the developing world, including India for that matter.
Sure.
So I think I must thank Andrew, Akhtar and the whole board for devoting this year for the diabetes nurse. And I think this is something very crucial and critical. And I think I'm very happy personally because you all know that I'm a son of a nurse. And so is Dr. Panikar, my partner. And I think nurse is grossly underrepresented in a country like India. In our clinic at Lilavati Hospital, our nurse educator is the key. She takes the history, she teaches insulin technique, she's the one who applies the CGM, she's the one who examines the feet, she's the one who dresses the small little foot wounds. So she actually doubles up as a podiatrist, as an educator, as a, see, because we are a resource limited country. Unfortunately, I've seen that in India, see, if you go to the US, it's a nurse practitioner, or if you go to Europe, or if you go to Australia, you will see that the nurse practitioners virtually run the diabetes care and delivery services. In India, we are grossly, you know, under understaffed, and we need to put nurse at the fulcrum. And I'm thankful to the IDF school and Andrew and the whole board for making this nurse education program for the nurses certification through the IDF school free of cost in this particular pivotal year over the next 3 months. And I would encourage that each one of you have nurses in your institution. They are the vital cog. Remember, many of these educators in India have been either dietitians or others, but nurses actually are far more crucial because they are certified to give injections, they are certified to implant devices, they are certified to install pumps, they are certified to do everything else. And now there is a structure put to it in the IDF school. So I think we need to ensure both hospital setups, small nursing home setups, as well as private setups, as well as public sector, to encourage that nurse diabetes practitioners become the order of the day. Imagine with around 80 million diabetics currently in India, slated to go above 100 million in times to come, it is impossible for 5, 6,000 or 8,000 members of RSSDI to manage those diabetic population. It is even impossible for our physicians who are around 20, 30,000 to manage this. So we need them to be, as Andrew said, one of the major contributors in care and delivery. If we aim to be the diabetes care capital of the world from India, we need to put the nurse at the forefront. And we have an opportunity which has been presented to us from our IDF, and we should grab this opportunity, ensure that we get more nurse engagement in our diabetes care delivery services across the nation. That's all I have to say. Bansi?
Dr.
Yes,
Bansi, would
I
you like to
agree
talk
fully with
about
Shashank.
your initiatives as president of the RSSDI? How would you like to change this, in our own country?
Thanks, Sanjay. And first of all, thank you, Dr. Andrew Bolton and Dr. Akhtar Hussain, for accepting our invitation for this RSSDA Diabetes Bite, which we are doing on our social media. So many of doctors who are following our RSSDA social media page, and at the same time, many persons with diabetes and their relatives and caregivers are also. On this World Diabetes Day, as Dr. Shashank already told, that we have the nurse which is mostly engaged in hospital. So we have diabetic nurse, but they are primarily in hospital setting. In a private clinic, we don't have many nurses. We have now supporting staff to whom we call as a educator. They are either diabetic educator or they may be the nurse. But now this year, what we have decided, there are nutritionists and our educator. And along with that, there has to be one diabetic nurse who can do all those things which are in India may not be possible for them to write insulin, but at least they can be available during this period of time for an online consultation or by some changing or some therapy. So that type of thing. And this year we have taken a great initiative, and with the help of IDF school, which you had already shown, and I have already done this IDF school, which is there across the country. We had sent to all our members also that this year it is for next 3 months. Online education is free, and many of the nursing and educators, they can become the part of this IDF school and they can get certificate of it. And this year we are primarily from RSSDI also primarily doing a nursing education program, and we are trying to make them a diabetic specific nurse or diabetic nurse who can be in India. Some parts of the country there is a diabetic foot nurse, so I mean that is more popular, but we don't have dedicated diabetic nurse who can do all and everything. But definitely in RSSDI we are planning to do. Dr. Akhtar wants to tell something, I think.
No, this is just to add something that I think this is I think we have talked about. Andrew has talked about the World Diabetes Day, the importance of the World Diabetes Day, as we know that he's rightly pointed that even though we got the UN resolution in 2007, but this World Diabetes Day was celebrating since 1991 together with the World Health Organization. So this is a long tradition that we are celebrating this World Diabetes Day, and this is to say that this that in order to the main theme is to say that this to secure that the access to care, the access to care is important, is because we know that in most of the parts, other than some European countries, welfare states like Norway. So even in the US, I have experienced, so many people do not have access to the important care, diabetes care. And this is one of the things that we need to for not forget on the World Diabetes Day. Having said it, this nurses education is crucial, but I also think that, for example, coming back to this Dr. Agarwal, that your first question of the uniformity of care, and I think that we need to think that our societies are different, our socioeconomic conditions are different, our cultural practices are different, and therefore, I think there will be differences. That differences should reflect for example, the socioeconomic status of the country, the structure of welfare, the healthcare deliveries, the structure of the health system in the respective countries, resources in terms of health personnel. So all these things, for example, I'm giving one example, Norway. If you think Norway is one of, as we know that we have very few people, we have a very, it's a rich country. And having said it, we actually spend more than any country in the world, if you think of per capita expenditure for health. But if you think that whether we have achieved the best health in Norway, possibly no. Still, you have to stand in queue for 6 months to get one MRI. This is the fact in Norway. So the challenges are everywhere. It's not that we hear that whenever I go to Bangladesh, my country of birth, that we have solved all the problems in Norway. So if you could simply follow the Norway, so we'll be solving all the problems. This is not correct. We have to see that how we can solve the problem in our respective countries. So I have worked, as I said, that I'm from Bangladesh. I feel very much as Bangladesh is a part of India. So I feel very much there. I have worked quite a long time in Africa. I have seen, and I also discussed, and having lived in Norway for no more than 35 years, I was thinking always that the uniformity, but I think that the diversity is not a bad thing, provided we can secure for example, let's say that I give one example, Bangladesh Diabetes Association is one of the poor countries in the world. But Diabetes Association of Bangladesh is providing service to all people with diabetes, no matter whether you have money or not. It's a charity in the sense that it's a non-profit organization. It has a kind of cross-financing. Those you have a primary, secondary, and tertiary care services, and you pay if you are on the tertiary care, but you don't pay if you are on the primary care. So it is working. And actually, Bangladesh Diabetes Association, as you know, that we have about 200 hospitals now all over the country. And the biggest hospital, that is called the Bardem, and I know that Dr. Bansi and Shashank both have visited, and hopefully that Andrew will one day visit this. So we see about 3,000 outdoor patients a day, 3,000 outdoor patients a single day. And this is probably the largest diabetes hospital in the whole world. It is financed by the Diabetes Association of Bangladesh. So you see that if you can create the proper diabetes care. So I think that it's a different model than what we practice in Norway, but this is functioning well in Bangladesh. And it is getting a kind of more and more recognition. Having said it, so I say that we don't have to have a kind of uniform care, but we need to see that whether we can provide the best services under the conditions. So that is one.
Yeah, sorry, please continue. I'm sorry I interrupted.
No, so this was my one thing. And for example, even the nurses' care, it also differs from country to country, even in European countries. For example, in Norway, nurse will not be prescribing insulin. This is not only India, not Norway. What they can do here in Norway, that if a patient's condition is stable and they want to continue with the same drug, so that they can simply continue with the drug, but not a new drug or new insulin. So it's a different way of practicing. So the practices are different. And as I said that in Norway, so for example, we have we call diabetes nurses. So that's another step that we need to come in order to say the creative positions. We don't have actually diabetes educators. We have diabetes nurses. The nurses actually provide the education education, and of course we have close collaboration with nutritionist. So nutritionist and diabetes nurse actually lay down the foundation. They are taking care. Doctor's responsibility mainly is to diagnosis and the treatment. So, but it's Norway. But I said that in Norway, in Europe, it also differs. So I think that we have to say that in Indian context, that what is right, and we have to say that given the qualification of the nurses, this is what is you have rightly points, Dr. Agarwala, that this is that we need to create qualified nurses and give more responsible and respect. And this is important. That I remember that when I was a medical student in Bangladesh, nurses had no position in the school, but today they are recognized as second-class gazetted officers in Bangladesh. So this has the current prime minister has taken this step because she's a woman, and then she made these changes. So the nurses get status. They are recognized as second-class gazetted officer, and they get higher salaries. And this has created kind of tremendous amount of interest among the students to get into nursing, which I have never seen in my time when I was a medical student in Bangladesh. So this is just to add to what you said.
So carrying your thought forward, and we have three board members of the IDF. The main challenges are two that we face. One is, of course, that I understand where you're coming from, that we can't have a uniformity of care across all regions. But can the IDF lay down minimum standards of care which need to be enforced by member societies and can play as an influential role to governments to see that this minimum standards of care are carried out across different regions? That's number one. And number two, what I would like to ask you is that, see, very often people want to know that how well trained the nurses are in diabetes care. And like you have the certified diabetes educators, CDE that is given in US and other parts, we don't have equivalent sort of, degrees that can be given to the nurses, which qualifies them. Now, it may be that the medical societies don't have these kind of options available in different countries. Can the IDF have a platform by which when they do a certain level of education, they get certified by the IDF to say that they have been well trained in the diabetes care, and that can serve as a qualification for them to get employability?
Well, firstly, let me say that the IDF is not for dictating across the world, it's for advising. And I think one needs to be cognizant and fully aware of the differences in healthcare possibilities in countries across the world. So we can give out principles, and we do give credits for courses at the IDF school. So we are doing that already. We have guidelines, but it's not for us to dictate, because we couldn't have a universal policy that will be applicable across the world. So we have to be sensitive to different regions, and hence we have regional 7 different regions with their own boards, and they can advise us as to the availability of certain facilities, for example, in different regions. So I don't know, Akhtar, do you want to add something?
Yes, as Andrew have said, that at the moment that what you do, I'm actually chairing the IDF school and IDF education at the moment. And what we have done now, this education that we have, this IDF school, it has been recognized and accredited by the European accredited system. So that is what I want to do. I'm asking all our regional chairs, including Shashank here, because Shashank has taken a great initiative to introduce this IDF school. Bansi has done it for a long time in India. I want the accreditation from the local, that I want the accreditation from India. I want the accreditation, not only that we have an European accreditation, but if we have the local accreditation, then I think, Dr. Agarwala, that what you said, that it would be easier for people to say that this has been accredited by the local. For example, if for example, this education system can be accredited by an credible Indian organization, that probably would be more suitable. And one thing we can do, for example, if we look at this, for example, the medical association in India, if they can take a look at this IDF education program, and if the medical board of India, they recognizes accrediting the IDF School of Education, And so that would help for some people, for example, nurses getting educated through the IDF school to be employed, because this has been accredited from India.
Shashank, would you like to make a comment?
Yes. So I think continuing with what Andrew and Akhtar said, the nursing school program is for any nurse which is registered with the Nursing Council of India. You know, every state government has a nursing council, and if you do this accredited program from IDF, actually we get credit hours for that nursing council. For example, we are from Maharashtra, Sanjay. If we get this credits of the IDF School of Nursing, which is free, any nurse, but she needs to be a qualified nurse with a registration from the nursing council. If she applies to her nursing council, we can get that accreditation done, that she can then claim to be a diabetic nurse. But the problem, as Andrew rightfully said, is every state and every country has their own regional ways for reimbursement, for qualification, for certification. But we at IDF can only be an advisory body. We can only be a facilitator, and we can ensure that we can get have some minimum standards of care. So whether you see the program of IDF school, which now Akhtar is heading, and the board is actively involved in, it has three components. It has a component for doctors, it has a component for the nurses, and in the doctors there are two groups. It says a component for primary care doctors who want to specialize, and it has a component for internists who want to do advanced care. So we need to ensure that we get these programs accredited by our local medical councils, and I think that is something which is very doable. And whether it is RSSDI, Diabetes India, or the Diabetic Association of India, they can actively partner with IDF, because you all are our member organizations, and we can ensure that in our region we can get this enlisted, and we can ensure that this program is accredited in India also. Currently it is accredited in Europe, and the standards of care for, say, for example, nurses, that has been laid down both by ADA and ESD, and there is a European Association for Nurse Educators, which also has defined all these guidelines. But the school has been cognizant of that, and one of the reasons the school was started as a global school was exactly the same. And I'm certain that this is the beginning. The school is very young, and I'm certain it's like a global university. COVID allows us to do a lot of digital education in this in these difficult times, and nurses are excellent care providers. As I said, probably many clinics don't have nurses, but me and Panikar, we run the Dream Clinic at Lilavati Hospital. Our clinic is actually run by our nurse, with fellows, with residents, with dietitians. But nurse is actually the case manager who runs the show. And in many parts of the world, that is actually the truth. So if you are able to use this as a system of care delivery, healthcare delivery, both in private and public sector, we can do that. And I'm certain that before this tenure of ours ends, we will have some more accreditation in place. But as I said, that we cannot replace a degree or a diploma which is given by a particular geography. We can only supplant them with appropriate diabetes education which is necessary for that region. Also remember, regional needs are different, and Andrew and Akhtar both are very cognizant and very supportive of our needs. And if we have some valid projects which are of high impact, the IDF has a facility and a provision to support them if we are able to do some research based on it, some educational piece on it. And that's something which we can discuss offline. But I think I must thank Andrew and Akhtar, both for keeping the school alive, both for keeping these different streams alive. And as we enter the centenary of insulin, ensuring that the nurse educators can be a big help in countries like India, where I feel it's very difficult to see 80 million diabetics by all of us. And I'm sure that all of you all, if you all are able to get nurses in your own clinics, they bring tremendous value on board. And I think if they undergo this IDF training program, which is a complete online program, they don't have to pay. They definitely have to learn a lot and get educated. It is accredited. It has a small little mini test questionnaire, and it's valid from the European system. We can try to attempt it to get it registered with the local nursing council or the national nursing council. And I think this is the first step. As I said, we need to take baby steps which are very firm, but that will lay the foundation in the next couple of years, so that, this is a contribution from our leadership under Andrew and Akhtar, which will actually lay down the foundation for future of care delivery of diabetes. Remember, the biggest challenge we are going to face today is that there won't be sufficient people to take care of diabetics on planet Earth, as there will be a tsunami of diabetes which is coming up. And I think whether it is prevention, whether it is treatment, whether it is care, whether it's complications, at each part of diabetes care delivery, I think our healthcare workers beyond doctors play one of the most important communicators. Not only they are counselors, not only they can give nutritional advice, not only they become technologists, not only they become and double up as pharmacists or supply providers, but I think they are the primary connect. They give that comfort, that compassion, that empathy, which people living with diabetes very much need. And they are a huge support for gestational diabetic mothers. They are huge support for our type 1 diabetics, insulin needing diabetics, our vulnerable population like the geriatric population, people who have handicaps like visual handicaps. I think this is a very key component, and we need to encourage them. And more we can encourage them at a national level in India, I think that is very welcome. I must congratulate Sanjay, you, Bansi, and the whole RSSDI committee for constantly keeping the flag high, even in this space. And I really thank you for allowing Andrew, Akhtar, and me to be there to celebrate this World Diabetes Week, which will be unveiled on the 14th, which is also the Diwali day. So there are, this is the DD week, the Diwali Diabetes Week, and therefore I feel it's very, very crucial that we encourage more and more and empower. See, it's all about encouragement. It's all about empowerment, and empower not only that the nurses can take care of our patients, but this also becomes like a patient empowerment tool. And I think the connection can happen better because we are very busy doctors. We may not have the time to spend with our patient. And I think the nurses can fill that up in a very, very effective way. In many parts of the world, many remote geographies of the world, including some of the most developed nations, the nurse practitioner even writes insulin, adjusts insulin pump, whether it is United States, whether it is some parts of Australia, some parts of Europe. So obviously, if we are able to upgrade this whole diabetes nurse as a movement now, and if we start and sow the seeds now, maybe in 5 or 10 years, we can have a very, very formal specialty of diabetes nursing. And that really can be a very good addition because that will change the numbers. Remember that we are the world number 2 and we are projected to be world number 1, but we should be the world number last. So that's something which we need to do.
Thought, yeah. I'm going to ask actually Bansi to actually take this forward. Yeah, please, Dr. Bolton, please go ahead.
Because I'm going to have to leave soon back to my other meeting. But
yeah,
a couple of points. First of all, Diwali, if I remember, is a big festival of light.
Yes.
Now, think of it as Florence Nightingale was known as the lady with the lamp.
Yep.
So there's a connection between light and the importance of the nurse. But if I could just pick up a couple of things that my good friend Shashank said. First of all, he mentioned the Federation of European Nurses and Diabetes. I think he was referring to that. Can I suggest that why not start something in your region? Federation of Indian Diabetes and Nurses and Diabetes. Find, that's a good one, you see. They can find people with diabetes and find the complications and treat them. And the second point, you mentioned the nurse having a multiple role, and India was part of the step-by-step program, which was set up by the International Working Group, which was a consultative section of IDF until the last couple of years ago, but we hope to bring them back. And they have done a great job with simple training of nurses, of people with an interest in the foot. And this has been shown in one study, for example, from Abbas in Tanzania, to reduce amputations. So this simple step-by-step approach that doesn't need any expensive equipment, that nurses can have a huge impact in, and it's already in many centers in India. So these are just two examples. A Federation of Indian Nurses and Diabetes, find, bring the light in with the Festival of Lights, the lady with the lamp, the nurse, and it's not just females, it's nurses, male and female. So let's be proactive and use this as an opportunity to raise the profile of the nurse in diabetes in your region, in this region of IDF.
That's a wonderful thought, and I'm sure Bansi and I will take this forward.
I
And
saw him
we'll
making
have...
notes.
These are pointers that we would love to take it ahead.
One initiative that we are going to ask the Indian Nursing Council as well as Medical Council of India to get the accreditation for our IDF school. And School of Education, we will initiate, and we will, the program which we are going to have for 3 months, which is free education, which they can enroll. So we will make sure that all our 8,000 members get that information for the IDF school. And very nicely, you had talked about FIND, which is Federation of Indian Nurse Diabetes. So that we are going to do. And already we have created a diabetic food task force under the Dr. Vijay Vishwanathan in RSSDI. And the similar type of program which we have done long back, I remember you, that is step by step, the same program we are going to repeat in our country next year. Yes.
So Bansi, I'm going to ask you a very relevant question that we see, as we have discussed in the last half an hour. There are a number of resources of learning, as we have just sort of outlined. The problem is, if you look at it from our own internal, I mean, our own country, we don't have the intermediate group, which Shashank has also been stressing on, the bridge between the patient and the doctor, which the educators, the nurses, the nutritionists fill up. As a precedent, can we motivate people to come into this sector and bridge this gap? Because we find that we lack that motivation from the nursing people or from the nutritionists for various reasons. They may not be paying too much. The nursing in the hospital becomes more, or they may not be enough diabetic clinics around where they can work. We have got now, of course, the IDF School for Learning. We have got our own 21 accredited centers of learning. So there is enough space for learning. The challenge is, how do we motivate the nurses to adopt this and come to bridge this gap? So as a president of RSSDI, what do you think you can roll it out in the country to see that people
One thing is, I already told you we have to do this program across the country. As already Shashank told, that these are the small steps and they will make the foundation stronger. And as Dr. Akhtar was telling that, in Bangladesh, they have the class 2 gazetted officer. Probably we don't have in India a similar type of status for our nurse. And that could be one of the reasons that we don't get so many nurses which they get, because they wanted to become the nurse. And then now we are trying to shift them not from the hospital nurse, we want to make them a diabetic nurse. So, I mean, it is an evolving process. And at this point of time now, many of our diabetes clinic, they are not even supported by nutritionists. And in future, we are looking for that all the, physician or all internist clinic, they should have at least 3 persons minimum in their clinic: diabetic educator, diabetic nurse, and a dedicated diabetic specific nutritionist. Already that we have started 2 programs last year for an educator. Already Shashank is running one more program of National Diabetic Educator Program with PHFI, Public Health Foundation of India. RSSDI is also doing the program. We have already with diabetic nutritionist, and now probably we will have a dedicated course which is again supported by IDF school. With that, we will teach and we will educate our nurses, and we will make FIND, which is Federation of Indian Nurses who are in diabetes.
He's already coined the acronym.
Yes, already it is. So we have to find that FIND.
Okay, so having find that, so having find that find, right? The challenge is, how are you going to motivate them to stay on and get better and better, and so that, see, ultimately we all realize there is a huge gap in care. We are not achieving our target goals for the patient that we outlined them in our different guidelines. And one of the key factors, of course, that the doctor has very little time. The patient has their own sources of information, which at times may not be relevant. And nobody to hold hand in between that, they can sort of guide the patients properly to the right path. And this motivation is lacking, and the skill set is lacking that we talk about. And that probably may be making all the difference between somebody getting to their goals.
So there are a lot of gaps in diabetes care, but I think during COVID time, when many of our patients, they want to do online consultation, and where I think the nurses' role will be important. And if we have the nurses which is in between, who can talk to the patients online, they can do consultation, they can do online some adjustment in their doses, and they can also talk to the doctor simultaneously. I think role of nurses will increase. And if we start educating our nurse and we can make them diabetic nurse, probably their role will be much more, and we will able to improve the care for our diabetic patients too.
I'm going to
So
direct
just
this.
a comment
Yeah.
I wanted to make that many of your centers don't have nurses as a part of your program. For example, I would welcome you all. I'll send you a video of Lilavati. If a patient comes to our hospital, first point contact and the case manager and the pro forma is actually made by the nurse. The first dialogue with the patient is made by the nurse, and also the exit is made by the nurse. In between, the nurse will, direct the patient to a dietitian, to a fellow resident to make examination, to the consultant, and then eventually hand over the prescription which the consultant writes and explain how the medications have to be administered, including teaching SMBG or AGP or insulin and so on and so forth. So the primary contact point is the nurse. So those models are existing, but in India the healthcare delivery is very heterogeneous. So we need to actually put a structure to it. There has to be some form of a incentive. We need to ensure that this is the biggest problem in corporate hospitals where we work is that nurse is never stable. So it keeps on changing, and if they have formal education, and most of them double out as very good podiatrists. We know that is Andrew knows this very well, that we have a huge shortage of podiatrists in India. So they really are, they fill up that gap very well. So if we are able to do this diabetes nurse practitioner model well in India, we'll actually be doing a lot of service to our nation in terms of our numbers. May not be now, but maybe a decade from now or 2 decades from now. So I think it's something which we can structure in a much more better way and take it up further for the whole region. In fact, I just don't feel it is important. Bangladesh already has a very well-oiled model in place, which is very, very good, and which we have seen. And we need to do it for the region. And of course, India is the largest part of our region. So I think this is something which we can do. And I think Sanjay and Bansi, with the enthusiasm you all have, we will be, I'm certain, we'll be able to change some numbers in India so that the projections can be beaten.
The challenge, of course, is, the hospitals don't want to invest in specialized nursing because the attrition rate is very high. They get trained and they leave and go away. So the gap continues to exist. I don't know how it is with Bangladesh, Dr. Akhtar. I'm going to ask you this, and I'm going to ask Bansi also this challenge that we face, that the nurses that you train don't stay with us for long and they move on. So the teams that you build up, they start falling apart because the people whom you have trained just go away. And that becomes a problem.
You see that, Dr. Agarwal, that if you look at, for example, doctors, we are also leaving our countries, but this trend has slowed down. If you look at India, I have recently read a paper where it was shown that, for example, beforehand people used to say brain drain. Now it says that brain gain, because we are seeing that more and more doctors from the US, from India are coming back. For example, highly qualified people from China, they're coming back. So why they're coming back? Because the opportunities exist. For example, you can say that why I live in Norway. Yeah, it has different reasons. Everybody has but collectively, we see the opportunities. We see the opportunities for our academic, for our careers, for our professional career, and also so. We see that we have created a kind of huge opportunity. At least I can look at in Bangladesh, that the opportunities that doctors have today, in my time, we couldn't even think of. So in a poor country, for example, if you look at that, what was the driving force for us to be doctors? The driving force for to be doctors was the possibilities doctors have in terms of its social status, in terms of the careers. So for the nurses, if we can create because you've said that, I do not know, I'm sorry, that maybe I'm sorry that in Bangladesh, I must say that the nurses, when I was a medical student, I mean, we didn't consider them as health professional, honestly speaking. I'm sorry, because they didn't have any proper education other than some training in nursing and care. Now it has been structured. For example, if you look at, for example, in Norway now, what we're doing, the paramedics. The paramedics, we are talking about, for example, these ambulance drivers that people used to say. Now we are making it a graduate program for the paramedics, lifted them up from giving them a status as equal to the nurses. Actually, the instead of calling ambulance drivers, we are lifting them up to the nurses, because the nurses in Norway actually, I'm diverting. And when I was in Brazil, then I was asking for a parking place, and they says that only the professors are allowed to have a parking space in the university. Okay, it's a university hospital, so we have only the professors, and the professors must have the biggest car. And I'm used to see that in Norway, the professors have the smallest car, nurses have the biggest car. So you see that this is the situation that we need to create them the opportunity for their career, for their income, and also social acceptance. If you see that I must say that it is changing. As I said, that in Bangladesh it is changing because they got a status, they got a second-class citizenship. But still, for example, there's lots of prejudices in terms of social stigma. For example, the nurse's canteen versus the doctor's canteen, there's a social segregation, which I do not know whether you are aware of, Andrew, but in European countries, we don't have any such segregation, right? So it's acceptance. So if we can create a kind of acceptance as equal partners, not necessarily that we are doing the same thing. I think I clearly believe that in a teamwork, we must be aware of our roles, that we are not stepping in always. I do not believe that nurses should be the small doctors or the doctors should be the nurses, but we must respect each other's area and their expertise, and they should have the possibility to pursue their career in their respective professional lines. And if you can create this opportunity in terms of finance, in terms of social acceptance, in terms of career development, I think nurses will be there. But I would like to add one more thing, that for which I need your help from the IDF school perspective. I want to have three different programs in the IDF school. One is the global one, that is everyone. Second thing is the regional, because as Andrew has mentioned, that every region has a different need. And for this, I want you to help, Shashank, and you, Bansi, Dr. Agarwal, that we need help from your region, including you can have a regional committee, because they said with Shashank as the regional chair, that region should say that what is the need, so that we can make it different. For example, the African need is different than what we need in Asia, so that we can make a kind of program that we call regionalized education program. And then we are doing a kind of supplementary education program. For example, let's say the Bangladesh, we have a, for example, education system, which is, of course, which was meant actually for the doctors, but later it became also for the nurses. And this has been continuing for last 12 years. We have more than 10,000 doctors already trained under this. So what we can do, instead of competing with them, I want to have a kind of complement, that what is the need that we can supply, so that we can have a complementary program, we can have a regional program, and we have a global program. So we have three different layers of diabetes school. I have discussed with Andrew, and I hope and I know that Andrew also agrees with me. And for this, I need your support from your region to say that how we can regionalize our education program, can be regionalized, suitable for Asia.
So that's a very good thought, and I'm going to ask Bansi to comment about this. That how can we keep our team intact in the country, because that's a very big challenge. The talent is very difficult to obtain, and having obtained the talent and we sort of put the teams together, they fall apart because they find better avenues of working. And it's very difficult to consistently hold teams together.
Thank you, Sanjay. First, we have to create the opportunity for our nurses. And the second, we have to educate them. So, I mean, the two things, if we have, probably we can give them more incentive to stay with us. That's number one. And second, for the Akhtar answer, because I want to be very quick, he had asked that there should be a regional, and from India under Dr. Shashank Joshi, who is our IDF Southeast Asia chairman, I can assure you that we will make the regional program for India, as well as we will help the Shashank also to make it for Southeast Asia. and that's our promise for the IDF school. And as far as nursing education is concerned, this year we will make sure from our RSSDI, which is going to be there from 26, Andrew Bolton will be our guest of honor to inaugurate. We have written only today only his mail to him. On that day only, we will make sure that this year we make this program of find nurse for diabetes. That much I can promise you.
Can I just add one point, because I'm going to have
Please.
to leave.
Yeah.
Yes.
First of all, as
Shashank,
Banshee knows, I'm an OCI anyway.
the last question.
I'm an OCI anyway, Banshee. You know that. Akhtar made a very important point. That is that the nurse in many countries doesn't feel an equal member of the team. And that's, if you can, it was difficult for us in England. As you know, we're very conservative in change, but it has changed, but it's taken years. But things can move fast in India. And we look at your progress, and you really need to make the nurse feel an integral and equal member of the team. So, for example, I'll ask my head nurse for advice. Now, that wouldn't have been heard of 30 years ago, or 40 years ago when I was a houseman. But they have to be an equal and valued member, and that's how you get them to stay.
Okay, before you go away, I'm going to catch you for one more minute. And it's a very important question. And I'm going to get feedbacks from all four of you. Do you think love, compassion, and care has been taken over by technology? And just as many would argue that stethoscope has become redundant, will care be controlled by technology in future?
I think technology is a vital part. We have to embrace it, but it cannot take over. And the best example of that is what's happened to my practice during the pandemic. And during the pandemic, especially in March, April, we're locked down again here because of, anyway, I won't go into politics, but at least Trump's going. But we were locked down, and suddenly in my diabetic foot clinic, I couldn't do an X-ray. I couldn't do a blood test. And the junior doctor said, "Oh, what about the X-ray? What about the CRP?" I said, "Treat the patient. Good clinical practice is still what matters in medicine. And we practice in medicine on an individual, not on the population. Look at the patient in front of you. If you can probe to bone, if there's a sausage-shaped dilatation, the X-ray is going to show osteomyelitis. Treat it with oral antibiotics. Forget the blood tests. Watch the progress." And that's been thrust upon us. And it's been a very good educational exercise. So in terms of foot care, of course, we're doing studies. We've shown that intelligent insoles can feed back to the patient in a wristwatch via Bluetooth and tell them that there's a high pressure under the foot. We use foot temperature measuring, but it has to be incorporated in good clinical care. And I think the future, you're always going to have a good clinical care and good clinical acumen and look and see. Medical students look, but they don't see. Listen to the patient and hear what they say. That's still very important. I rest my case, my lord.
Dr. Akhtar, I'm going to come to you for the same question. Do you think love, care, and compassion has been replaced by technology?
You see that technology is something is undeniably marching in. Technology, we are more and more dependent on technology. And particularly in this COVID-19, we can see that how much we have become dependent on technology. For example, telemedicine. We are becoming dependent on technology. For example, today we see that, for example, particularly in COVID-19, the laboratories were run by the robots because in order to avoid the contamination. The robots who are in China, they are used to deliver foods to the patients. Well, of course, I was not there. I have seen it, and on the TV that they were so they are coming in, and we see that, for example, surgery. For example, if you say one part of the surgery has already been taken up by robots. So question is that we cannot avoid for example, the coming in of the technology. Question is that how we can make the technology more sensitive to the patient's need. How can we make the technology more intelligent so that the patient with technological development, or for example, a robot can read the human mind. And that is the biggest challenge that is coming in. What Andrew is referring to, I remember, Andrew, that we used to talk of clinical hands. You see, that today's medical students, they don't have these clinical hands. We used to say that when I was a student, we used to treat symptomatically, not that we are waiting for the blood test results. You look at the symptoms, as you said, that you hear the patients and you have your clinical hands, and then you start the patient. So these things, I think that for us, Andrew, is still true, but I think it's fading away with the newer students, because they are becoming more. And in Norway, I said that it's gone already. Everything they do, they have to ask for example, blood tests, X-rays, and XYZ, all these kind of tests, and they'll be waiting for it. Beforehand, they will not do anything. So I think that, having said it, so I think that technology is something inevitable. It is coming in. Our challenge, our medical communities, to have a dialogue with those people who are developing this technology in order to make them more intelligent, so that they can be more sensitive to patient care. So that would be the biggest challenge.
I'll take the final comment from Dr. Shashank. We're running out of time, but I'm going to get a quick comment squeezed in from Dr. Shashank for his views about this.
So I think it's a very good question. And my answer to that is technology can never replace love, compassion, and care. Remember, technology adds to the clutter. It creates more confusion. It generates anxiety and negativity. So you need a technology to be a very important partner, but there is no substitute to love, compassion, care, and being felt. The most important thing a patient needs is a listening ear. And for that listening ear, there is no technology which can do that. You can't really substitute fundamental one-on-one patient-doctor communication with any technology. You can use technology to facilitate care. For example, in COVID, we are all speaking rather than meeting. Okay, so we can do that. We can have a virtual interface in that. But remember, technology adds to clutter, generates anxiety, and not necessarily may make a difference on outcomes. They still need to generate that data. We need to live with technology. We need to embrace technology. But I think there is no substitute to love, care, and warmth and being felt. That connection, the eye-to-eye contact, that little tap, that little one-on-one with you and your patient can never ever be substituted. And as Andrew said, there is no substitute to history taking and clinical care. I think that will always be remaining supreme. I understand that there is a big challenge in a US-centric legalized world where they look at more of papers and computers. I think it's important to engage the patient one-on-one. And in diabetes care, it's a vital cog. So I think love, compassion will always score over technology, but technology can only be an enabler or a facilitator at best. Thank you.
Well said.
Thank you very much, Shashank. We have run out of time, but I'm going to take the cue from the last statements that we all need to have love, compassion, and care for our patients. That's the number one, I think, edict of medical profession. And unless we really follow this up in our clinical practice, we'll never get our patients to feel that they are being cared. And I think that's the most important crux of all our discussion that we are doing. Nurses play a very pivotal role to ensure that they are, the bridge between the doctor and the patient, and they're able to carry out all the thoughts, the plan that, we put together as team. And they have a very important role to play in our care teams. That role can never be divided or replaced in any kind of a way. So with this few thoughts, I would like to thank Dr. Andrew Bolton, Dr. Akhtar, Dr. Shashank Joshi, and Dr. Bansi Sabu for being so nice to have spent this last 60 minutes with us. Very thoughtful, very informative, and I think all of us are going to take back with us very good memories and take home messages, which I'm sure will be very useful. And for Bansi and me, you've given us a lot of food for thought as to how we can take RSSDI forwards for the future. And I'm sure, Dr. Akhtar, as you come in as the president-elect, you will have wonderful opportunities to make impactful futures for the entire world. So we wish you lots of luck. And Dr. Andrew, thank you very much for being our current president. You have made such a lot of strides in the care delivery systems, as well as the idea of school and so many other thoughts. That has been wonderful to have you as our president. And we look forward to always being engaging with you in future too. I'm going to hand this over to our social media team, who's been very dynamic and who's been working very hard behind to see that the RSSDI initiatives are carried forward to all the population across the country. We established the social media team, and I'm going to ask Dr. Purvi Chawla, a representative of the social media team, to propose a vote of thanks.
Thank you, Dr. Sanjay. It was a fascinating 1 hour. And on behalf of the RSSDI social media team, I'd like to start by thanking our audience for their support, following, and interest in our series. RSSDI Diabetes Bytes, organized by our team, is extremely grateful to this very elite panel of experts who are extremely busy, especially this week, celebrating the multiple activities related with the upcoming World Diabetes Day, recognizing nurses and their role in making a difference in the lives of our people with diabetes. So thank you very much, Dr. Andrew Bolton, Dr. Akhtar Hussain, Dr. Shashank Joshi, Dr. Banshi Sabu, and Dr. Sanjay Agrawal for sharing your vision, expertise, experience, and all those lovely taglines and messages. Lady with the lamp, diabetes and Diwali, educating and empowering, and finding the find. What you shared today is indeed invaluable as it helps to build and consolidate our army of crusaders combating diabetes. We, the social media team, couldn't have thought of a better tribute to celebrate the World Diabetes Day. Thank you once again for your time and effort. And I'd like to take 30 seconds more for a social message. Diwali has already set in here, bringing cheer and happiness and a ray of hope from the current pandemic situation. But let's not get ahead of ourselves, guys. Please, folks, wear your masks correctly, avoid crowds, maintain your distance, and thorough hand hygiene. Thank you so much, and stay tuned in. Next week, we'll be back at our usual 7:30 or 7:30 with RSSDI Diabetes Bytes with yet another very special endeavor. Thank you so much.
Thank you. Thank you.
Shubh
Happy Diwali to
Deepavali.
everybody.
Happy